No. I'm just the MC. You guys are the important ones. Okay, thank you.
And then Todd, can you come up on stage just for the video, just to capture? But then you're going to be walking around probably.
Okay. Yeah. I still I was assured that I needed to do no prep for this.
Correct.
So I followed the guidelines, instructions to the letter, and I have done no prep.
It's just asking people if they want to share their experience, their story, one aspect.
Basically, you just need somebody to be able to hold a mic around.
Yeah, but then they're going to say stuff, and then you're going to comment on it a little bit, and don't hog the mic. You know, try to get as many people as possible, but obviously they're going to say things that you really need to comment on, and so you comment. Okay. I think Cannon will jump in if there's things, and I'll jump in.
Cool.
Lewis will jump in. He's over there.
I just wanted to tell you that I really enjoyed hearing you back in 2015 when we were over, you came in 2015, didn't you?
I can't remember when it was. It was in Arizona. Whenever it was Arizona.
It was awesome.
Yeah, so it was actually someone else that you enjoyed hearing in 15. That's what you're thinking.
But he looked like you.
Right, yeah, but he was really handsome.
No, but I did. It was awesome stuff. Thank you very much. Okay. Now I'm almost ready.
No, I'm just trying to. So that is, you want to go.
Okay, it's going to be short and sweet. Testing, 1, 2, 3. Testing, 1, 2, 3. Well, I want to hand the baton because, you know, you want to. Well, no, I want to.
Hey guys, we're gonna start again if we can get back to our seats.
That sound good?
That's perfectly fine.
Okay.
What I did want to mention as a follow-up to the last presentation is there's some low-hanging fruit. How many people are the only person in their family to have periodic paralysis? So there's like a bunch of, quote, index patients that are, you know, maybe spontaneous mutations. I thought I was a spontaneous mutation for 20 years. And finally, I convinced my, mom and my sister to get tested, and then they tested positive and explained a whole lot of like unexplained symptoms that they were having their whole life. So it's low-hanging fruit. If you're the only one in your family, provided it doesn't cause major, family. I mean, there's a lot of things with genetic testing. You can't just go and test. There's a counseling and everything, but it may be wise to, think about having that discussion with all genetically related family members to see who might have it, because you can prevent a lot of bad feelings, with appropriate medication if indeed they end up having it. All right, Jeff.
Thank you. Okay, our next speaker, Dr. Todd Bell, is a pediatrician in the Amarillo, Texas area, and has over 18 years of experience. He attended the University of Arkansas College of Medicine and graduated in 2001. He's affiliated with Baptist St. Anthony's Hospital and Texas Tech University Health Sciences Center, both in Amarillo. Dr. Bell sees many children with periodic paralysis and is the golden standard of care for these young patients. Dr. Bell.
I'm confident that no one actually put I was the gold standard for care of these patients.
It's the gold standard.
It's right, okay. They assured me that I didn't need to do anything to prep for this, and so I followed their instructions, and so this is wide open. I would like, if it's okay, I'm going to steal the mic for about 90 seconds. And one, just to explain why I'm up here, mainly they just needed somebody to carry a microphone around, is my understanding, and I'm able to do that, and so I'm going to fulfill that role. I actually got into periodic paralysis because of those atypical patients that Dr. Tarleton was mentioning, and that's actually the majority of the patients that I end up seeing who have paralysis events, and so again, some of those other symptoms will be something that we may talk about tomorrow, I think, because I'm going to have another opportunity tomorrow to speak. The other thing that I was going to do is just agree with Dr. Tarleton in that there is definitely a need for developing some sort of research network, I think, and I think that that's something from the standpoint of the PPA and perhaps beholden on us as physicians as well to find a way to be able to drive that forward. With that, what am I supposed to do now? Dr. Levitt?
You know, the idea is this is just a chance for everyone in the audience to, you know, to share your story or some aspect of your story, because it's important for all of us to hear each other's stories, challenges, questions. It's kind of open time. I found this to be the most essential part of every conference that I've ever been at. And then, you know, all the doctors in the room can comment.
All right, and with that, we'll start right here.
Hi. So I was diagnosed about 10 years ago, and then just recently we found out that it is in my family. My sister who's here with her daughter has it, and her daughter has it, and both of my children have it, but they're older. They're 20 and 25. So now that we are aware that it runs in our family, it appears to be part from my mom, part from my dad. It's the SCN sodium channel variant with the chloride channel. My dad had the chloride channel. With all of the kids are in their 20s. My niece, who is here, she seems to be the most symptomatic. My children, my daughter seems to be a little bit more symptomatic than my son. So the girls tend to be a little bit more symptomatic. We do know that food is a big trigger, stress, all of those things. But now that we know what it is, how can we help our children moving forward? Maybe, I mean, we are doing the treatments with them with the potassium and stuff like that, but my physical abilities have been severely limited from when I was younger, and I really want to try to prevent that for my children. And I don't know if the potassium they're taking every day, the diet that they're doing, is there something else we should be doing to keep them from getting the muscle weakness and that type of thing?
So we should also put a disclaimer that, as far as I'm aware, there is virtually no pediatric data in the literature. There's, again, if anybody else wants to weigh in on that, there's nothing. That being said, I think, first of all, very common questions and very good questions. And I think that there's a lot of things that we need to, it again highlights the need to really move forward with some of those clinical type studies to answer questions that we all have. You know, what does it do to the body when you have a child who's on a high dose of potassium for long periods of time? We just honestly don't know. I think that, at least for myself, and we'll certainly see if anybody else wants to weigh in on this, when we're thinking about prevention of problems down the road, I don't know of anything specific to the ion channel disorder itself. However, there's this whole cohort of other symptoms that also seem to be associated as well. For example, a lot of folks will have issues with hypermobility. Dr. Tarleton mentioned hypermobility. We know that with hypermobility, you have an increased risk of joint dislocation. And if you use Ehlers-Danlos hypermobile type as sort of a model, or benign joint hypermobility syndrome as a model of that, what we do see is that once you injure a joint once, then oftentimes you'll have recurrent injury of that joint. And so being aggressive, for example, like with physical therapy, trying to rehab joints, may be something that specifically when you're thinking about long-term function, musculoskeletal function, that may be something that is useful. We tend to be, in my hypermobility clinic, we tend to be really aggressive with rehab if it's a rehabable joint. There's some that aren't, like fingers, next to impossible to be able to strengthen the fingers. You got to really look at like ring splints if someone's having finger dislocations, or ankles are kind of interesting. So the ankles, we do try to do physical therapy. There are specifically some things they can do. I think the PT usually starts working with the, for example, the anterior tib, try to be able to improve the arch, try to improve or decrease some of the inturning of the ankle when we're walking, which causes a little bit of stretching. And and by doing that, that oftentimes can be helpful. But it's one of those joints that sometimes we also have to do bracing to be able to prevent problems down the road. I do think there's a lot of folks who have adult patients who have PP, or I suspect that there are a lot of adult patients with PP who actually have long-term functional issues that are primarily probably not due to their sodium channel issue or their calcium channel issue, but rather due to just that unrelated hypermobility that causes that wear and tear on the joint over time.
Oh, so, okay, question though. No, over back here. I'm back here. Turn 180 degrees. This is
like
God.
I'm on the road to Damascus here.
I think, the question might be, though, you have a child, they're 5 years old, you have a genetic diagnosis, they have a genetic diagnosis. Maybe their symptoms aren't that they're flat out paralyzed. So, and, like I wasn't flat out paralyzed till I was 12. But I remember eating Lucky Charms and candy, going outside and feeling like I just feel like garbage when I was like 5 or 6. And, I just assumed that, oh, well, everyone gets the sugar crash, I'm sure that was, had I taken potassium, I would have been like, oh, So, like, when do you give the kid potassium? When do you give the kid Diamox? And how much?
Again, great question. Well, and so this is just purely what I typically do, is if the child is symptomatic to the point that it seems to be affecting their activities, mom's noting that little Johnny just never wants to go run play at recess, or the teacher has noted that. If it's something that seems to be affecting those activities of daily living, then I think it's probably worth starting to intervene on that. And some of those things like throwing away the Lucky Charms, or even better, sending them to your pediatrician because he doesn't get paid much and he likes Lucky Charms, would be very reasonable place to start, because obviously no kid is going to be harmed by a Lucky Charm deficiency. So some of those behavioral and dietary things, I think that's a great thing to do even if a child's not symptomatic. But if we're starting to think about using the medications, I think it really has to be, are we seeing any effect on those activities of daily living? And I don't know of a great test for that.
Are you asking the child, like, honey, are you tired? And how, when do you let up and when do you?
Right. Well, and that's part of the struggle, is because, again, kids tend to be fairly susceptible. So if I have when my kids were smaller, now I have teenagers now and they're not susceptible to anything I say, but when they were younger, I could make a suggestion and they'd, I'm tired, or, it's, sweetheart, it's 8 o'clock, aren't you feeling a little sleepy? And they're like, yeah, okay, I guess so. So I do think you have to be cautious with that, but certainly if it's reached the point that the parent has noticed or suspected or is, and I also totally realize that as parents, we also have a tendency to be real intense in our observation about our kids when there's something that we're watching for. But I think if the parents have noticed something, or at least they have a suspicion that there's some of those effect on activities, then maybe it's worth intervening and trying to intervene. Again, part of our issue is it's that balance. We don't want kids to be symptomatic, but we don't have great data in children on really any of these medications that I'm aware of.
Question. So since we started, this is my niece here, since we started, since now she started, just like what you were saying, her and my daughter, my son does not take it on as a need, what is it? I'm sorry. As needed. My niece and my daughter do, and they say that it has changed their life. But they should just keep doing it as needed, right? Not on a daily basis. Like me and my sister take it every single day to prevent an attack, where with them, they're okay right now doing it as needed, right? Or should they be doing it?
It's going to be a trial and error kind of thing.
I think it is. I think the one thing similar to little Jake's Lucky Charms experience, he may not, or he didn't realize and didn't know that was different until he threw away the Lucky Charms or started taking potassium. So I think one of the struggles is, it is trial and error, because one of the struggles is you probably didn't know how good you were going to feel until you took the potassium. And it's like, wow, where did all that, you know, the energy come from? How is it that I'm able to get up and go now and I couldn't yesterday when the same thing happened? And so I don't know. There may be a role in trying to schedule things and see if there's a noticeable difference. I would suggest to you that if you can't find a difference, if you start taking it on a daily basis and you're like, man, I'm not sure that that's doing much, then I would probably back off and go back to the PRN, because as far as I'm aware, there's not any data, at least from a pediatric standpoint, that putting our meds in on a regular basis is gonna prevent an issue down the road. So it's really just kind of, is it going to be able to help with the symptoms and trial and error?
And we got over here.
Hi, I'm Miriam Breslauer. I'm 42 now, but when I was a child, I didn't really have full body paralysis, but I'd have random acts of weakness, or especially when I was doing sports, I'd be running down the basketball court and all of a sudden I'd feel like I'd run into a wall. And nobody around me, but just all of a sudden stop, and then I'd have to crawl off the court in the middle of a game on a regular basis, pretty much every time I played. And my coach just told me that I needed to lose weight, and I wasn't active enough, or not practicing enough. But over time, my skills in basketball, for example, got much worse. Like I couldn't shoot as far, I couldn't shoot as accurately, even though I was practicing as hard as I could. And it's just an example. I don't know if other people might have that as warning signs that periodic paralysis might be a problem, or might be a sign that there's something wrong. But people kept telling me that it wasn't abnormal. But for me, it was like nobody else is going through that.
Yeah. Well, first of all, you know, I don't have periodic paralysis, but I also suck at basketball. So that may be that's probably irrelevant. But you do raise a very good point, and I think that is that one thing as your general pediatrician, if you tell your general pediatrician, hey, I'm concerned that my child may have periodic paralysis, and they go and they Google it or they look it up in Nelson's, then they're going to come up with a single paragraph that says something on the order of, you know, you have these paralytic events. And so they're going to say, well, you know, has your child been paralyzed? You know, no, you know, they just seem tired or weak or having trouble, discoordination. And so I think that sometimes for those of us who aren't periodic paralysis experts, we may have a more difficult time realizing that actually can be a sign of what's going on. Now, we obviously know, certainly in the adult population, is not every event or episode is a full paralysis episode. And so I think that one of the things that we try to kind of sort out with the kids, and honestly we depend a lot on the parents and the family for this, but do they have episodic weakness that's not otherwise explained? And that episodic weakness certainly could be evidence that we have periodic paralysis that's there.
I will say, and there's someone over there, I will say that a lot of people just, you know, they wake up in the morning and it takes them a half hour to get going, and they're tired, and they just assume that that's the way they are. Just like I assume that, well, after you eat a candy bar, of course, you get tired and then it goes away, instead of realizing, hey, maybe I should be under treatment. So I guess you have to pay attention to the symptoms, and that's also the family members that are undiagnosed. If they have that kind of thing, like there are entire families that wake up slow in the morning, and and only one person has the diagnosis, and they realize that everyone has that. And the question is, you know, how aggressive do you treat, right? Like, should I be taking more potassium, or am I functional enough? Should I move from acetazolamide to Keveyis, and maybe I'm going to get a better response, or should I leave well enough alone? That's that's always tricky.
Agree. But here and then there.
And we'll go around and we'll get everybody.
With it primarily being skeletal muscle, that is where the ion channels have been identified, is there any crossover into whether skeletal muscle mutations can impact smooth muscle function in an area, kind of GI tract type thing?
I actually have an answer to that, or I have a suspicion on that. But does anybody else who's actually a geneticist and knows, or a neurologist knows about these things want to weigh in on this?
I mean, there's certain areas where both a voluntary muscle and smooth muscle are acting on the same system, like bladder control and things like that. So there are instances where a channel defect in striated skeletal muscle will affect function, but the big players, the sodium channel, the calcium channel, the chloride channel, are not expressed in smooth muscle.
I think my only thing, and appreciate that, my only thing I would potentially add to that is if you're concerned about, like with gastroparesis or small intestinal bacterial overgrowth or functional constipation, functional diarrhea, those type of things, those are things that are all controlled by the autonomic system, and we're going back sort of towards the atypical a little bit here, but the difficulties in regulating the autonomic nervous system have been associated with certain hypermobility syndromes, and we don't understand why there either. But certainly autonomic dysregulation, and again I would use EDS hypermobile type as sort of a model of what that looks like, but all of those things in the GI tract do have autonomic control, so it's not a direct relationship to the ion channels that are involved with PP, but maybe something else that's related, just because it seems like at least that hypermobility is more common in PP population.
And we'll take over.
Right here.
Oh, yes.
Sorry.
Sorry. Wow. I totally need to get my glasses changed. Or...
We just barely got diagnosis for my husband. He's very atypical. His potassium levels are always normal, but he responds as a hypo, so potassium supplements help him. And we have a daughter that's like extremely atypical. She has been diagnosed with an autonomic nervous system disorder, and since she was like 1, she passes out often. When she got to be 12, she started passing out much more, which is a normal thing for young teenage girls. When it was the worst, it was 10 times a day. But she also started having the full body muscle weakness, more likely happening after a passing out episode. Could there be a link between the passing out triggering?
So the great thing about yes, no questions is I can say yes. So there is actually, and again, I certainly don't want to hijack from there's some science that we know because of a lot of the great work that's been done by some of the folks in the room here even. There's a lot that science just hadn't caught up with what's going on. There is at least a biologic plausibility that's associated there. Again, that autonomic regulation, the association with hypermobility, this clarified relationship of hypermobility with hypo or hyperkalemic or with ion channelopathies. But with the autonomic system, the most common type of dysautonomia in children is actually going to be a hyperadrenergic dysautonomia. So basically that's if you have the sympathetic nervous system, which is the fight or flight response, and then you have the parasympathetic, which is kind of the veg out and chill. And so the sympathetic is if a bear walks into the room, then I'm going to get this big uptick in my sympathetic system, because I need to be able to run away from a bear. With the parasympathetic, it's kind of what happens on Thanksgiving afternoon when you're sitting on the couch pretending to watch television, but really you're just trying to stay awake. And so it's the balance between those two that affect a lot of different organs. Well, some of those organs that are affected include the adrenal, the hypothalamic pituitary adrenal axis. That's part of that autonomic system. And we do know that when we get that adrenaline, it causes a lot of different things, but one of the things that it does is that part of what it does is it actually shifts potassium back into the cell. So the same sort of reason why sometimes we'll have patients with PP who will trigger because of a startle, that presumably that may be the same thing, same sequence of events that's happening there. So with the hyperadrenergic, so too much of that sympathetic nervous system, like with POTS, postural orthostatic tachycardia syndrome, may have been the diagnosis that
Well, she doesn't fit very well in that bucket either, because
Okay.
she can be sitting still, not doing anything, or having a conversation and pass out.
So I wonder whether, one of the things that we kind of have thought about or speculated on a little bit is that if you have a kid who's predisposed to the autonomic regulation issues, so you end up with flares of the sympathetic nervous system, those flares in the sympathetic system then cause the release of the cortisol and that those adrenal axis hormones, which in turn are going to shift some potassium into the cell, thereby dropping the, just like if you're giving somebody insulin or a donut, then that may actually trigger events. I had one little boy who has adrenal insufficiency that we finally had figured out that what the deal was every morning and afternoon, and it didn't happen every time, but he'd take his replacement hydrocortisone that he had to have for his adrenal insufficiency. But if he, when he did that, then we had this little drop in the potassium. He'd dropped down to about 3.2, and that was enough to have him go into paralysis. So we were able, in his case, just to be able to schedule potassium at the same time that he was taking his daily medicines for his adrenal insufficiency, and that was able to at least decrease the frequency of events. But it is tough. The hyperadrenergic dysautonomia that we see in kids typically gets worse as they start to go through puberty. So the ages 11, 12, 13, usually it typically kind of evens off a little bit after that, and a lot of kids will actually grow out of the autonomic issues. And then by the time they're in their 20s, that's gone, even though obviously the periodic paralysis may still be there. But if the stress overreaction, the adrenergic dysautonomia is a trigger for the paralysis event, that at least may get better as she gets older. Now that doesn't get you through high school, but at least there's a light way down at the end of a very, very long tunnel.
Okay.
I now have
We got someone over here.
How'd you get another microphone?
I got connections.
Hey, yes, he
Jake's got like 6 microphones,
He's El
just like stuck in his
Presidente.
pocket.
He can do anything he wants. I mean,
I guess.
so. Obviously, I'm in my 30s. Growing up, it showed up. I don't know, with you being a pediatrician, I went through years, we don't know what it is, but also, too, in the limelight, are you seeing kids or even young adults dealing with periodic paralysis and how they're managing with ADHD or anything like that, or anxiety? I know, like, when I have anxiety attacks, I burn through myself so quickly that I'm crashed within minutes afterwards.
Yeah, so I think great question, and everybody's pointing to people that they know.
Before you answer that, I also too am noticing, like, I've just recently diagnosed autistic, so I'm sensory overload again, also causing major crashes too.
Absolutely. So again, the disclaimer that we've got no real data on this. When you're thinking about anxiety, and especially if you're thinking about panic attacks, and someone who's a neurologist is gonna laugh at me when I try to describe this, but basically, as you think about the portion of the brain, the neuronal circuits that are actually processing emotions, and how that communicates what those emotions are to the rest of the body. So what we feel as anxiety is not actually something that just goes on in the head. It's how our body responds to that sensation or that emotional processing that we then label as anxiety. So if I gave a medicine to, if I give somebody epinephrine, which is going to be something that kind of jacks up that sympathetic nervous system, that's going to, they would at least potentially feel anxious. So again, I don't know that it's something that it's a direct ion channel issue, so that it's not necessarily directly related to the periodic paralysis, but there has been a couple of studies, and actually a nice little study that was, I can't remember where this was done, within just actually the past 4 years, that they went through at a tertiary psychiatric department, and they went through and they basically did what we call a Baton score, which is a way of checking to see if someone is really flexible. in their patients who had generalized anxiety disorder. And about 80% of patients who have a generalized anxiety disorder actually are hypermobile. And if we think about what is hypermobility, that's a small 10% of the population. Biology is a bell curve, not named after me. And you have 10% there that would be more hypermobile than everybody else, just like 10% of people are taller than everyone else. Well, 80% of the people who have anxiety are in that 10% of the population that's hypermobile. So again, the thought then is, all right, is what we're seeing as anxiety or panic attacks, are those actually an autonomic issue, an autonomic regulation issue, which as you start to think about, you know, PTSD or some of the work that's been done on use of beta blockers, treating the way that we treat performance anxiety. If someone's getting up in front of a group and is going to be speaking and they're really nervous and shaky, what do? We give them something that dampens that, that fight or flight response. And lo and behold, they don't feel as anxious. So I do think there's probably a link. There's no direct link from an ion channel standpoint that I'm aware of. But again, we have this whole list of ancillary symptoms that are not explainable, in my mind anyways, directly from that ion channel, at least the ones that we know of, as far as genetic mutations, but it seems to be a recurring theme.
But you can definitely see a feedback loop. If you're anxious and you have adrenaline, and adrenaline is a cause of...
Are you like under a table?
You know, as a trigger,
oh.
it,
no, you're standing right beside him. I'm sorry.
It cycles through.
Is there any chance you could get like one of those little orange triangle flags or something and just sort of attach it so I can see you? I'm having trouble here.
Yeah. I got to... Someone else.
I think we had one here.
Okay.
We'll go...
So this is kind of a long question, but it's all part of the same question, I promise. So we're hypo. Myself and my son and daughter have it, clinically diagnosed, and so we take a lot of potassium, and the potassium works, but we had a doctor ask us where the potassium goes, and I tried to tell him it goes in the muscles, but he said, but it doesn't stay there forever, and so I'm thinking that we pee it out when we're not in an attack, maybe. These large amounts we're taking. So the second part of the same question is, I have reduced kidney function by quite a bit, and I'm wondering, are we damaging our kidneys by taking this potassium, and is it safe? I mean, obviously we have to take it, but I'm wondering, is that what's going on here? Also, I have symptoms of, well, tea-colored urine sometimes, and a lot of times on the same days that I'm very achy, so I was wondering if that would be possibly rhabdomyolysis. Myolysis?
Sure. Yeah. So the potassium does, we think that the small fluctuations of the potassium are probably intracellular shifts, and then it does come back out, and then the body pees it out. And there is some data that the kidneys accommodate to chronic large potassium dosing. So the which is part of why we sometimes have difficulty depending just on potassium to be able to manage symptoms, is because over time folks get better. Their kidneys are just really good at peeing out potassium, and that's where some of these other medications I think sometimes come into play. I don't know of any data as far as I'm aware, there's no data to say that taking the potassium as a child is going to cause kidney issues later on. But again, there's just not a lot of data that's out there from that standpoint. And with tea-colored urine, certainly rhabdo would be one thing we would think about. I don't know. There's so many things that can cause issues with the kidney. I don't know that I would necessarily say that it's likely that the reduced renal function that you have is necessarily because of prior potassium use. Even like the rhabdo itself, if you know, because there's other things that can also predispose to rhabdomyolysis. And someone who has had rhabdo, that can actually cause kidney damage as well. Anybody else want to weigh in on that one? Jake, is he back under the table?
Yeah, I'm back here. I changed position. I'm here. I think anecdotally, so you have elevated kidney function? Or
reduced.
Reduced. I mean, reduced.
Yeah.
So I mean, I anecdotally, if you take the whole population of periodic paralysis, I haven't heard. We take a lot of potassium. I haven't heard of renal function being reduced on that basis. Rhabdo will mess up renal function if you have recurrent serious bouts of that without rehydrating and stuff. So maybe that is a thing, but it's more of a nephrologist.
Would the rhabdo be caused by the periodic paralysis?
I guess that's like a heavy word, the rhabdo, but there is some muscle breakdown that happens when you have attacks, and if that happens on a massive scale, then yeah. I wouldn't call that as a definitive, and it's something that you'd have to kind of like notice what it is, do the blood tests, and make sure there's a temporal correlation. And if it happens twice and 3 times, then you start correlating it. But it would be like a one-off. You have a question?
Yes, my daughter's 13, and she started showing symptoms at 1, but wasn't diagnosed until 4. Neither myself or my husband have periodic paralysis, and we've been genetically tested, all 3 of us, and my daughter's been published in the medical journals. We've noticed, as of the last year and a half, a decline in her health overall, in her ability to walk. So she went from being able to walk last year to not being able to walk, and she's been in this wheelchair now for probably about a year and a half. And I guess as a pediatric doctor who sees patients with these conditions, what would you say or recommend? I mean, we've seen things that do kind of help her overlying condition as far as episodes go. She's on liquid potassium and Cavis, but I guess the physical ability to walk has kind of been our biggest concern, losing, just her youth, I guess.
Sure. Anytime that we have a kiddo in a wheelchair, that when we want them to be out kicking soccer balls, obviously that gets us. Just to kind of clarify, so the with the HPP does she have one of those 4 common genes, or do you know what the genetic variant was, or?
The variant was R897S.
Which channel? Sodium, calcium, potassium?
I think it's the calcium.
Okay. So the I guess one thing that I would just mention or think about is with the decline in function in spite of therapy, I would actually, and so she's being treated, and you guys are on that, and she has this progressive decline. I would also be just scratching my head about, could there be something else unrelated that's going on? Now, obviously, you've got some great docs who've been taking care of her, and I'm certainly not second guessing them. I will say, as physicians, we have a tendency sometimes when we get ourselves into a little bit of a rut, once we know what we think we know what's going on, it's hard sometimes to be able to look outside of that one pathway, that diagnosis that we've already put into place. And progressive weakness, I'm not familiar with that particular variant. I don't have any other kids who have that variant. And so it may be something specific to that particular calcium channel ion issue. But I would also at least keep my eyes open. Could there be something else that's also going on there?
Well, I guess over the years she's had a lot of,
We've studied 897S in the lab. It's the most severe leak of any hypo-PP mutation we've ever seen. So unfortunately, there's a pretty rational explanation for why your daughter's symptoms are coming at a much earlier age than would usually happen in hypo-PP, and she's much more profoundly affected. I'd love to talk with you at this meeting about it, okay?
His answer is more definitive than mine. Sorry.
Yeah. Oh, I know you. We're going back and forth in the room, so you go someone down there, I'll go someone down here.
You mentioned you had a patient with Addison's and periodic paralysis. I'm a pediatrician, and my patient is actually my wife, who has Addison's and periodic paralysis. She runs into a problem where she needs her sodium for her Addison's, but she takes too much sodium, it affects her periodic paralysis. Where do you get the balance?
Be turning that one to Dr. Cannon as well. I don't know. I think it's a trial and error. I do think that at least with this one kiddo, the one thing that we did that was actually really helpful with this particular kid was timing timing some potassium when he was going to be taking his hydrocortisone. And we end up writing up, you know how it is with adrenal insufficiency. Everybody's got a letter that you take. If you have to go to the ER or if you cut off your leg with a chainsaw, then whoever is supposed to read that letter and say, hey, this is what I'm supposed to do. We're going to do whatever your doc's doing, 3 times the usual dose or whatever it is. And so we just actually basically just hijacked that and then added in that, with the standard dosing, he was going to take X amount of potassium. With a stress event, if he's getting stress dose, we're going to do this other amount. That may be worthwhile. It is, I think, though, really difficult, in part because there's so much variability in physiology just from person to person. Not that the physiology is different, but the magnitude of any physiologic process varies from person to person because of genetic variability and body mass and all those different things that happen. So good luck with that.
We have over here.
Oh. Hi. I come from a large family where there are about 30 people who have some sort of symptoms of PP and muscle weakness. We are yet as to be diagnosed or have a conclusive gene defect. But one thing that I found, it seems there's a suspicion that the symptoms can get worse for each generation. And I've never stumbled upon that possible fact in any literature. So my question is there any evidence at all that PP can get worse for each generation?
And I think it's a wonderful question for us to ask our geneticists. Do we have geneticists? I'm not aware of any data to say that we have that. And there definitely are genetic diseases that we see that as a pediatrician, not for the life of me that I can think of one right now, but there are frequently, like with tandem repeat mutations, like with, is it Huntington's, maybe, that you get worsening over time?
A dermatology, I'm sorry.
Yeah, okay, all right, yeah. We're of no use to you on that.
Steve's comment.
These are the trinucleotide repeat expansion diseases that get worse with successive generations. So there are some that affect muscle. Myotonic dystrophy is the biggest one. It's the most common form of muscular dystrophy. If your family has not been screened for myotonic dystrophy, you would certainly want that to occur. But for the conventional forms of periodic paralysis with the ion channel mutations, there's no progressive worsening with successive generations that I'm aware of.
I actually do know something about myotonic dystrophy. I should have been able to answer that. Yeah. Right. My turn? Do we have anybody? Yeah. Oh, we're right over here. Yeah, I handed my mic away. I was really hoping you were going to actually answer that question earlier when I handed you the mic.
He's going to pass it off to wifey. I was clinically diagnosed hypo in 2012, and then last year tested positive for RY-R1 variant, and then our daughter also tested positive a few months ago and has been showing signs. She's 8, yes, she's beautiful, wonderful, we love her just the way she is. But she tested positive, and we've seen some signs. And her pediatric neurologist is very kind, had never heard of the disease before. So she's open, but she does not want to put her on potassium supplements because she tested normal, in the normal range. And I've said her mama also usually tests in the normal range, but needs it. So I guess I would love some advice as far as how to talk to her doctor. I am not a medical doctor, don't claim to be, but I do have a mama's gut and suffer the disease myself. And we try to avoid triggers as much as we possibly can. That's how we've been managing it thus far. But I would really love that option if it's something that is supported in the community. My husband's whispering to me, maybe he's going to say, maybe I should mention, she's also on the autism spectrum and has ADHD. So,
Yeah, so I think, you know, going back to kind of like we were talking earlier, I feel pretty strongly that if a kid is, if they're symptomatic to where it's affecting their activities, I mean, you know, we can tell that the kid has symptoms. I really think that they need to be able to be treated, and at an absolute bare minimum, they need to be able to at least have access to the fast-acting potassium, right? And so because we got to have that emergency plan in place. How do you approach your doctor on that? It is difficult, I think, because we don't want to. Sometimes us doctors have kind of thin skin. We get our feelings hurt, and nobody really appreciates us. Also, sometimes as doctors, we need to just suck it up and realize that we don't know everything. I think that when you're approaching the physician, I think that in my mind anyways, if you can present what the issues are, what your concerns are, and then open it up to what do they think is the appropriate treatment. Then, and you can certainly, you know, after they do that, they say, well, I think we just need to watch and wait. Then you can say, but my concern is this, you know, what if we're in an event and she has her first big attack, and we go from these sort of subtle symptoms of, well, she seems a little weak on Tuesdays after soccer, to all of a sudden now she's laid out over on the side of the soccer field and can't move. What do we, you can just ask your doc, what do we do in that hypothetical situation? Because the answer is not, oh, well, we'll cross that bridge when we get there, because we got to have a plan in place to be able to project what might happen down the road. And then, and I think that maybe if you can use that as a jumping off point to be able to say, you know, well, you can even, you know, say Dr. Cannon said that you should have some sort of emergency potassium and or whatever. But again, at least let them have that opportunity to think through it. Because I will tell you that and then if you still aren't comfortable with that, even though your pediatric neurologist is a lovely person and it may be difficult to find another one, I think that arguably the most important thing you can get out of your physician is someone who's willing to listen to you and take your concerns seriously. And I think that if you're not getting that, if you're uncomfortable with that, and you've talked to them and you just don't think it's going to work, then I think you maybe need to look for a different pediatric neurologist. I will tell you the medical system is designed for the 80% of patients who are average patients. Average from a disease process standpoint, average from a payer source standpoint, average from height, weight, location, distance from the physician. This system is unintentionally, but it's designed to accommodate that 80% of folks that are close to the median. And when you start looking at things like periodic paralysis, you're really outside of that 80%, and it becomes much more difficult to make this system work for you or work for the patient. And it almost seems like you're having to work against the system to get anything done. It is, I think, a really difficult position, especially if it's someone who's a well-meaning doctor. And I guess another potential thing would be reaching out to the PPA or to one of us and just to be able to talk through what the doctor's concerns are. So if your doc wants to give a call, and I think that probably, but I'm sure Jake does a lot more than I do, or some of our others, but even I occasionally get phone calls that there's a doc who just wants to say, hey, I had this patient said that, you know, they want to do such and such. Is that completely crazy? And I'm like, no, that actually seems like a really good idea. And oftentimes that can also be reassuring to your physician as well.
Yeah, but we leverage PPA Ask the Experts that way, and if you can ask the question, or hopefully the doctor asks the question. That's like so rare, and then like I can connect the doctor to a neurologist or myself, and we can sort out those issues. My question, two questions. I guess you can get to a diagnosis of periodic paralysis by the hard genetic test, and you can get to it by clinical diagnosis. So for sure, you're clinically low potassium, you get better with potassium, you have bouts of weakness. So clinically, your periodic paralysis. I feel comfortable making, you know, recommendations if there's a clinical basis. The other thing, I guess, a question for Steve is so the RYR, is that like a thing now? Is that like a new? Should we be saying sodium, calcium, and RYR?
Jake, it's a thing. We're on a first name basis. So. In all seriousness, the challenge with the RYR story is it's one of the atypical variants of periodic paralysis. There aren't enough experience isn't enough experience yet to know how responsive it's going to be to potassium. As you heard from Todd, it's potentially big bang for a small buck, right? Potassium is relatively safe if you have normal renal function, so it's certainly worth a try. But scientifically, we cannot connect the dots about why it should even be hypo versus something else. But clearly you've experienced that, and that's the most valuable thing. But the RYR1, I would predict they're also going to play out a little differently than some of the traditional voltage-gated ion channel ones that we heard of. So as I'm sure you've read and are aware of, problems with RYR1 can present in many different ways: malignant hyperthermia, central core disease, mini multi-core disease, all these other things. And just the overlap of those muscle syndromes is still an active area that's being worked out right now.
If I could just add something that I don't know whether it's helpful or not, but you know, there's a lot of really well-meaning doctors out there that actually just don't have the information. And so over time, I've just found our collective curiosity and the fact that we just love to read and we just never give up. If you haven't found the article that Jake wrote in 2008, which is practical aspects in the management of hypokalemic periodic paralysis, it's a great starting point for everybody, but it's a great starting point for a lot of doctors. Yeah. I mean, we live in Toronto. We've got a wonderful hospital there with a lot of unbelievably well-trained specialists. And when Matt was first diagnosed very, very early, we got a diagnosis very accurately and very early. But in terms of the actual management of the issue afterwards, it's a little bit of hit and miss. I think it's a lot of self-advocacy. It's a lot of trial and error. And then it's a lot of trying to get past the doctor's bias as to what is acceptable. Like I remember, to use a very simple example, and then I'll be quiet, but most doctors that we've encountered think that he takes an unreasonably large dose of potassium. And then I remember talking to Jake when we were in Ireland at the last conference, and Jake, through his own self-advocacy and self-management, has figured out that prior to going for a workout, you can have a ridiculously large dose of potassium, which most doctors that you run into who are unfamiliar with the disease would say, good God, never do that. You're going to have a heart attack or some other problem's going to happen. And so, again, it's one of the reasons why we're here, is to share those stories of what can you get to in terms of acceptable levels of both dosage and trial and error. And, but that article is a great one to start with a lot of doctors that just haven't crossed the line yet. And again, at the end of the day, I personally think that the right diagnosis is unbelievable, but I also think the practical aspect of how you deal with it every day is more important from my simplified judgment, because at the end of the day, we're all trying to live excellent lives. And so the practical aspects of managing the thing are a pretty big deal. So thank you for writing that article.
Yeah, I would also shout out on that article. I keep a copy of it on my laptop.
Thank you so much. No,
right. But there was actually a follow-up on that one question. And one of the things that did actually make me think that, you know, you might try negotiating with your doc about what would be, for example, the potassium dose that they would be comfortable with. Check labs afterwards. They don't even wait, not even waiting for an event, but just take a dose. If they're like, boy, I just, 5 milliequivalents, that's going to be pushing it. Okay. Well, let's give 5 milliequivalents, and then let's check potassium. And lo and behold, it's not going to be 7.3. And that may then create some comfort level for your doc to say, boy, you know what, actually, I guess we really could go up, because, and then obviously it means you get stuck a bunch, but it does create a little bit of comfort for your doctor. Because your doctor wants to do the right thing. You had a follow-up on that?
I guess I was just thinking in terms of longevity, due to our daughter being 8 as well as other pediatric populations. But from a potassium versus, I know the neurologist also brought up acetazolamide. And I guess I was just thinking from a standpoint, thinking back to her concern with renal function, as well as other organ damage. I mean, as we approach it with our neurologists, is there concern or a better initiation point? Like, is potassium better to start with rather than looking at?
So, and this is just my gestalt, and other people would have a probably better feel, but I think that potassium is fine to start with. I think that if your plan though begins and ends with potassium, I think that you're potentially missing a lot of other opportunities. Again, the kidneys accommodate. The body's very good about putting the potassium back where it thinks it's supposed to be, and so it's really hard to capture enough potassium over a long period of time, day in, day out, to be able to really prevent issues. So I think that it's, most doctors are going to be more comfortable starting with potassium than they would starting with, because when they were in residency in the NICU, they were given, itsy bitsy little babies, preemies potassium. And so they're going to be comfortable with doing that more so than the Keveyis or acetazolamide or spironolactone or something like that. Even though I really think that at some point your plan, unless low dose potassium just on a PRM basis, if that controls everything, great, no reason to do anything else. But you certainly wouldn't want to limit your therapeutic options, in my opinion, just because she's 8.
I mean, the short of it is that a lot of us in this room have been taking acetazolamide since we were teenagers, and we're now 40, 50, 60 years old. It's not messing up your kidneys if you stay hydrated. And if you take decent doses of potassium, it's going to make your paralysis go away and not hurt your kidneys. So I think, and certainly in the short term, you want to know if these drugs work. So you have the tools, and then you can decide to continue them or not. But, you want to have eyes wide open, versus just being paralyzed and tired all the time. So, you have to weigh those risks and benefits.
I would also say that Jake is not the poster child for carbonic anhydrase inhibitors. So don't let how he turned out scare you from your children being treated. So.
Hi, my name is Nikki, and I am clinically diagnosed with hypokalemia, as well as my 16-year-old daughter. I just want anybody that wants to talk to me about their kids, their teenagers, their experience, compare notes, find me. There you go.
Outstanding. And I actually have some questions about my teenage daughter, so I'll be chatting with you later.
So this guy right here, stand up, started on Diamox when he was 6, and at that point they were a little concerned about whether or not it would affect growth, and he's 6. Apparently not. So anyway, if any doctors are concerned about that, you can let them know it doesn't.
He's a more positive poster child than Jake is.
Surely.
Oh, yes. Sorry.
Hi, my name is Vivian, and my son is diagnosed hypo with the calcium channel, and he's also hypermobile Ehlers-Danlos syndrome. And online, I noticed on Facebook, a lot of EDSers also have hypo. Is there any sort of link that you found for that?
Yes. Any other question? No. So we don't understand, or at least I don't understand. Smarter people may very well, but we don't think that the collagen laxity that we see in EDS hypermobile type has really anything directly to do with the ion channel issues that we see with PP. But it keeps coming up, and just, as you work with patients, you just find that lots and lots and lots of patients who have issues with periodic paralysis also have joint hypermobility. And EDS hypermobile type, certainly the most common, and even though we say that, it's 1 in 5,000, the reality is that there's so much overlap with something called benign joint hypermobility syndrome that you're really probably looking at maybe 0.1% of the population or so could actually have that or meet the clinical criteria for EDS hypermobile type. So there's definitely some connection. I'm not exactly sure what it is. Again, we just really don't know. But there is I'm confident there is some connection, and it's because it's just you see it over and over and over again, and there's got to be some explanation for that. Anybody else want to take a stab at the whole EDS thing? Because I'm lost. Again, it was actually one of my patients. I'd never even heard of that. And then one of the first PP patients I was seeing, her husband actually disconnected her lower leg and sort of turned it like 90 degrees and put it back. And they were trying to, they were trying to convince me that her knee was unstable. And I'm like, whoa, you could have just said, I think my knee's unstable. You know, put that back where it's supposed to be. Don't do that again. So again, you just see it over and over again. Someone had their hand? Yes.
One thing that I've noticed, or that I've noticed a lot reading online, is that people say that, you know, as you get older, you get fewer and fewer instances of the paralysis. Well, in my situation, I mean, I wasn't diagnosed until like a year ago, but I've been having symptoms like pretty much my whole life. I can remember things back from when I was like 5. But the weird thing that happened with me is that it hit me really, really hard around 14 or 15 years old and kind of followed me up to about the point I was 30. And then I didn't have a lot of problems between 30 and 40, and now it's like hit me hard again. And I don't know if that is something that's very common, where people will go a long stretch of time and not have a lot of issues. And then suddenly they have a lot of issues again, or, because everything I've read seems to, like, I should be starting to get better by now.
I am exactly the same way. So you and I need to talk, okay?
Any of my adult colleagues want to take a stab at that one?
So there are recognized connections between hormonal status and susceptibility to periodic paralysis, particularly hypo-PP, particularly the calcium channel mutations, particularly R528H, if you're in that bucket. So one of the best studies on this, very large family in the Netherlands, over 40 affected individuals, huge 5-generation family that Tara Links and her colleagues described. And so many of the women did not experience episodic attacks classical for periodic paralysis, but then in their 40s and 50s began to get permanent muscle weakness, proximal weakness, difficulty climbing stairs, things like that, whereas the men were much more likely to have the episodic attacks and then develop, unfortunately, the progressive weakness as well. In fact, that one family is one of the strongest conundrums of the fact that it's hard to connect the dots between frequency and severity of episodic attacks and subsequent risk for late permanent weakness. It's because, you know, that seems to break that rule. But of course, there could be lots of subclinical episodes that, you know, don't rise to the level of appreciation that's wear and tear on the muscle. The other hormonal thing is that, and Todd, I'd be curious in your experience, the textbooks say, and a lot of the textbooks are wrong, that more typically, hypo-PP has its onset at puberty and later, whereas hyper-PP presents more commonly earlier. There are exceptions to all of this. There's some nice large studies now with histograms, and it's kind of all over the map. But that was the initial impression, and so there was another hormonal connection there. And I'll actually show you tomorrow our mice with R528H. The female mice are not as severely impacted as the male mice. So there are definitely hormonal things there. We just don't completely understand.
What I think might come out of this is, you know, we talk about papers that say, like, you know, redefining periodic paralysis, and maybe it's time for a kind of seminal redefining periodic paralysis to break all of these preconceived notions that block diagnosis for so many folks. I think we have to call it. Thank you, Dr. Bell, for your moderation.